Hello everybody, this is Kyle Byron, the Toronto Nutritionist. Has a personal trainer or any other non-medical professional ever told you that your hormones are out of whack or that you have metabolic damage? Well, these are some terms and diagnoses that get thrown around a lot at the gym or among fitness professionals. And I really wanted to get to the bottom of these things with an actual professional. So we have something really special. Today I have an interview with Dr. Karl Nadolsky, endocrinologist. I'm going to highlight a few of the other things we're going to talk about in this interview. And you diagnose hormones without laboratory testing and more about laboratory testing and what they actually do and how reliable they are. We talk about fat deposits, like different areas of body fat, and can you spot reduce? And what is metabolic damage and some of the other terms that we talked about. And should we bother eating right or exercising to manipulate our hormones? And spoiler alert, yes, you should. But we're going to get into the difference between the hormone changes that you can experience from lifestyle changes versus medical changes. And then who should really be pursuing a medical diagnosis regarding their hormones. And then who can we trust, speaking to about our hormones. Now I would like to tell you a little bit about who we are speaking with today. This is Dr. Karl Nadolsky. He is an endocrinologist, or in other words, an endocrinology physician. He is also a doctor specializing in obesity treatment. So he has about 5 years of specialization after completing med school, which is 4 years, and before that, a degree, which was 4 years. So that is a lot of education. That's what you might expect from a specialist in his field. And so we're very fortunate to have his expertise today. And oh, by the way, this is also Dr. Karl Nadolsky, same guy, just wearing a different shirt. And as you can see, it says, "Does your doctor even lift?" Dr. Karl Nadolsky is a former Division I wrestler. He's a husband, he is a father, and he is a promoter of healthy lifestyle and medicine when needed. He walks the walk, he stays in good shape, well, or you could say actually superb shape. And again, we're very fortunate to have his expertise today. How's it going, man?
Not bad.
Crazy time, right?
Yeah. Well, and I happen to be the inpatient diabetes endocrine consult guy this week. So, anyways, there's a silver lining because we've been pushing for more telemedicine and virtual care, and this is forcing our hand. So we're kind of on the cutting edge of that. We've been pushing for it for so long, so now we get to prove that it works. So we can do a lot of it just with a chart review. Even a lot of the endocrine stuff, I can make most of my recommendations either talking to the primary team doc or just doing a chart review. There are a few endocrine things where it's nice to examine somebody, but even then, we can often do it without, being right next to the person. We can do it from 6 feet away.
Understood. Well, I really appreciate your time today, and I'm just going to give you a chance to sort of introduce yourself. Dr. Karl Nadolsky, endocrinologist. Actually, one of my first questions will help sort of explain who you are. So, how long does it take to become an endocrinologist?
Well, you gotta. For all doctors, you have to complete undergraduate training in some sort of degree with all the pre-medicine requisites. So, that could be anywhere from, I guess, as short as 3 years to, I wrestled at Michigan State, so I was redshirted for a year, so that's 5 years. And then I coached with some extra classes for another year while I applied to med school, so that was 6 years for me. And then medical school is generally 4 years still. And then internal medicine residency is after med school, and that's 3 years. And then depending on if you do research focus or clinical focus, endocrinology fellowship can be anywhere from 2 to 3 years. Generally, it's becoming more of a 2-year training program to be more focused clinically. Unless you're really going to go into research.
Okay. So I'm already sort of laughing on the inside here because this whole interview is about
sort of the fitness industry or the nutrition industry and how certain claims are made around, hormonal management from some of my, I wouldn't say they're colleagues of mine, but people in the industry who I sort of know about, and I'm sure you come across this on a daily basis, and I've seen some of your posts regarding this as well. So fitness professionals who make claims about being able to manipulate hormones and versus, the extensive training that sort of doctors go through. And unfortunately, I guess we're in a time where science is maybe not as trusted as it should be. And I guess I'm making I think I'm making a gross understatement there. Science is not really being trusted right now. I think we can agree on that.
Yeah, in all sorts of different manners and realms. And and to be fair to, people who are into fitness and diet and stuff, there has been a lack of, dietary and exercise education in medical school specifically, just because the way medicine has been historically has evolved, I think. Now those of us who specialize end up with a lot of nutrition and exercise education and things like that. And, and I also am certified in obesity medicine, so that adds a whole nother layer to it. But that's one of the things that's trying to improve is a little bit more nutrition and exercise in med school. So there's some of that too, but then it goes both ways, right?
Interesting. Yeah. So a practitioner that I know claims that he can tell what hormones are out of the normal ranges by looking at fat deposits or where a person sort of carries body fat, whether it's their back or legs or abdomen. And so my first question is that possible to make that determination?
Yeah. So I guess I'd have to see the specifics of what that person was declaring, because one thing we have to establish is that there are way more hormones by definition in the body than what we even really study. We try to study a lot of them in research to understand physiology, but even like a clinical endocrinologist like I am, there are tons of hormones, many hormones that may or may not have true pathological issues that we don't necessarily get into. And in that respect, that person is not being truthful if that's the case. Now, here are a few examples of where there's some truth to it. So we know that those who store their adipose tissue more in their gut, around their organs, which means ectopic fats in their liver and in their muscles and in their pancreas, and their peripheral healthy fat cells, like in their legs and arms, are not working as well. That, that's a little bit more of that metabolic syndrome, insulin-resistant risk of type 2 diabetes. And on the extreme end, there are a variety of diseases called lipodystrophies, where the healthy peripheral fat cells really don't work. And then there are a variety of the severities of that. So in that respect, that's to some degree true. So I can look at someone and know if they have what we might call a, kind of an insulin-resistant elevated waist circumference of obesity. I can look at them and know if I think they may, have one of those forms of what we call lipodystrophy, where the healthy fat cells don't work. But we're gonna confirm those things in lab work. That's not just a physical exam thing, like you're saying. But so there's some hints there, and then of course, one of the rare but famous hormone problems are the Cushing syndromes, where we have too much cortisol, our stress hormone, coming from our adrenal gland or being stimulated from our pituitary gland, or rarely a severe form where that cortisol stimulating hormone, or ACTH, is being produced by like a cancer somewhere. That's called an ectopic Cushing. So in that respect, when we look at somebody, if they have fat deposit in the back of their neck, sometimes called a buffalo hump, or in the area we call the supraclavicular. So kind of in front. So when you can't see their clavicle and there's, we call it fat padding, supraclavicular fat padding, or dorsal cervical. That's the back of the neck. That's the doctor term for back of the neck. So those are associated with and the face too. So facial rounding, the moon face. Those are associated with too much cortisol or Cushing syndrome. Those are Cushingoid features. But there are other things too. You know, they have arm and leg wasting, so you lose muscle. You might get thinning and bruising of the skin that's beyond normal. Females might get hair loss or hair growth where they don't want it. Big purple stretch marks that we call stria. Hip weakness. That's Cushing syndrome stuff. But there are some fat deposition things in that exam that lead us that direction. Beyond that, not so much.
You asked me like what these specific claims are, and this practitioner is using a body fat caliper to pinch, various areas, and then from the millimeters of body fat on like the scapula or subscapula compared to their waist, or waist compared to, then they're using the measurement to decide, okay, your cortisol is too high or your blah blah blah.
No. Especially not if he's talking about cortisol. That has to be biochemically determined. Those, like I said, the moon facies, the supraclavicular, dorsocervical, fat padding, those are signs, but it's still going to come down to biochemical testing, and it's a pain in the butt diagnosis, by the way.
What do you mean by that?
It takes an extraordinary effort, and because people don't understand labs are not perfect. There are lab errors. The lab assays are much more complicated than what people understand. I even think far more than what most doctors understand. And I'm no lab technician or anything, but endocrinologists often at least understand the complexities and the potential errors of lab assays. And so in Cushing's, perhaps our best test is a late night, middle of the night, or bedtime salivary cortisol, because your cortisol should be low right when you're going to bed or in the middle of the night. But you throw off your sleep patterns in any way, and that can screw that up. If you do it wrong, that can screw that up. And of course, there are always going to be false negatives, but it's kind of one of the best as far as specificity and sensitivity, which maybe people don't even care about those words, but that's whether you get false positives or false negatives, all that stuff. And then one of the simpler ones is what we call an overnight dexamethasone suppression test, where somebody takes 1 milligram of a glucocorticoid called dexamethasone at night, and that should make your cortisol level go down. And so then in the morning you get your cortisol drawn, and it should be less than 1.8 basically in the units we use. But that's there can be slightly false positives, false negatives. If females are on estrogen therapy, it can increase something called cortisol binding globulin, so that might give you a false positive. But that's an otherwise nice screening test. And then we do 24-hour urine collections. Those are, there are kind of a wide range of kind of gray area in those results. So they're not great, but they can help certainly confirm and monitor. Then anyways, and there are a couple more, intensive ways to do it in the hospital if you're not sure. And then you got to decide, well, where's it coming from? So you got to do ACTH and DHEAS testing. That's just seeing if it's pituitary or adrenal or ectopic. And, it gets more complicated. And then even if you really suspect it and you can't prove it, you got to kind of keep it on the back burner and never forget it. And that may actually get to one of your other questions, by the way, about how people can, fit people can look or can stay in good shape despite stress that allegedly increases cortisol, even in a normal fashion. But
we'll get to that in a second. So I'm trying to keep up with you. I have a degree in science, and I've looked at lab work myself, but I can hardly keep up with you. And this is really great.
It's complicated.
And that's our whole point of this conversation. That's the whole point of this conversation, is that, what you do, Dr. Nadolsky, is extremely complicated in assessing people's hormones. And for someone with, a fat caliper and a personal training certification to declare that they can detect hormone levels is just outrageous. Would you agree with that?
I would agree with that.
Okay. Thank you. Okay. Next question. So these practitioners that, use these calipers and make these declarations about their hormones, they suggest, or they come out and say it, that they can help clients reduce fat in certain areas by certain behaviors of, nutrition and lifestyle. How do you respond to that?
Well, yeah, that's the spot reducing thing. I mean, I kind of thought that myth was debunked long ago, and I thought that's even more sort of known in the fitness, the exercise phys and dietitian world. That's you can't spot reduce. And now genetics plays a role, and as far as kind of that metabolic syndrome sort of ectopic fat, there may be a little to that, but not really. I mean, it's a lot of it's genetic, and no, you don't spot reduce. You hear about people who say, oh boy, when I gain weight, I gain it here, and when I lose weight, I lose it here first, and that's sort of an individualized thing based upon genetics, and it's hard to manipulate that. You can't do crunches and get abs if you have adipose tissue over your abs. You know what I mean? That's going to be the whole thing. The diet, exercise, everything else we do.
So the practitioners that make these claims are motivated by, like all sort of, snake oil salesmen. They're preying on the fears of the people that have this, stubborn body fat, or they're just looking for that next diet craze. So when these people are saying, oh, yeah, we can spot reduce, that really resonates with people that are desperate to, sort of get results. So I mean, it's in my education, this was debunked and so on and so forth. So I guess they're just sort of bastardizing some acute medical situations and applying it to the general population, I guess is what we can say.
That seems about right.
Okay. So my next question, which you alluded to a moment ago, if stress limited fat loss, how do we explain all the stressed out humans that are very fit, like professional fighters, people in the military, or literally any mom who is in good shape? So the first thing is that there, of course, is something to it. Stress is something we address with weight loss and a lot of different areas of medicine. Stress isn't good for us. Too much stress. But you also have to be able to have a stress response. So, if you're too stressed out, there is something to, activating that hypothalamic pituitary adrenal axis that we were talking about. A little too much cortisol, maybe, but it's not pathological. It's not Cushing syndrome. It's not Cushing's disease. You know what I mean? It's a little bit too much. And by the way, when you have too much adipose tissue, that's sort of a state of excess cortisol because the enzyme in the fat tissue is inactivating the cortisol, or it's activating the cortisone, the cortisol. Cortisone's an inactive form of it. Anyways, pregnancy is a natural state of high cortisol, due to stress. And so we need some of that. People who have adrenal insufficiency, they crash and burn when they're under stress. So you have to have some cortisol, and it is good for us a little bit. Too much is bad. But so we do work on stress reduction, and it, that may play a role with some of our brain hormones that certainly work against us with appetite and cravings and energy balance in that way. But even people who have pathological Cushing's disease or Cushing syndrome, especially when it's not severe, they can be missed because they might not look like it. So one of my mentors, who's got to be in his 80s now, old endocrine guru, always said, hey, he was talking to me. He's like, you are the perfect example of someone who, if you get Cushing's disease, people will miss it because you won't look like it. You'll find a way to not let it look like it because you eat so well and you exercise so much that, I have the genetics and I've been doing it forever, so I stay pretty lean and mean. I work out all the time. My muscles stay pretty good, and I look healthy. So if I developed Cushing syndrome or disease, and that's pathological, too much stress cortisol hormone, it might be missed for a long time unless I go, hold on, guys, something's really wrong with me. Yeah. And I got to start looking at myself. So especially when people are under, reasonable stress, when you're teeing up your diet and exercise and maybe trying to do stress reduction stuff, you certainly can find a way to not be, have it work against you. In some ways, it does work against you, and we should always work on stress reduction. But you're right, it's not something to hang your hat on. I mean, because obviously,
athletes are all stressed out, both physically and mentally, and like you said, moms and
right.
Doctors, although not all doctors stay in good shape because and some of it might be stress, not getting enough sleep in residency. So and this is part of the problem with some of the stuff out there. There's a little something to a lot of things, and then they take it and run with it. And we get into that with some of the naturopathic stuff and some of the alternative practitioners. They'll take a little bit of truth and then blow it up into their thing and try to make money off of it. So, stress reduction is important. Trying to keep things at bay. Cortisol does play a role, but it's not a pathology.
Okay.
It's not a huge clinical thing that people are just going to be able to fix with manipulation. Whatever behavioral manipulation. Yeah, we want to work on stress reduction.
Okay. Well said. Well said. I'm learning a lot, really, how to put all this into words. Like when you just said, people find a little something, there's a little truth to it, and then they blow it up, beyond the clinical accuracy.
Yeah, that is a huge problem, I think. That's probably the biggest problem we deal with these alternative people trying to prey on the vulnerable that you mentioned.
Okay. I think we've sort of covered this, going to ask it anyway. So if hormone replacement therapy was scored 100 out of 100 for its ability to change someone's hormones, what would a dietary change or a lifestyle change be scored? Like if I wanted to change my testosterone or HGH or something by eating differently, different lifestyle.
So again, this matters is there really a pathology or not?
Let's say no.
So if there's not a pathology, then I think in the single digit percentages, you can optimize a lot of your hormone function by that stress reduction, good sleep, quality diet, not too restrictive, not over energy abundance, appropriate exercise, not overtraining, and not being sedentary. Now that said, there are always going to be these caveats. So, for example, with testosterone, that's where guys think of it, right?
Yeah.
So the most common hypogonadism or low T that I see and that we probably all see is what I would call a functional hypogonadism, and it's usually due to obesity, maybe poor sleep, or in that sleep apnea, which is pretty common. Those things all cause a functional hypogonadism, which we can treat with lifestyle. So if we can, we got to get that lifestyle to result in weight loss, or maybe better sleep, or sleep apnea, using a CPAP machine, and so we can fix that. Now, on the other hand, highly restrictive diets, overtraining, etc., and even those who are really, really, really lean, like, natural bodybuilders, athletes, some of us have certainly been there, where, we know that puts you into a functional hypogonadism state. And we also know that relatively commonly in females, the female athlete triad, where, often, for better or worse, associated with gymnasts, because they work out so much, they eat so well, they're so lean that they don't have the, their estrogen axis working. And so, and that has some problems. So those are functional hypogonadisms. Also, other examples are, I guess, like I told you, we talked about some of the stress states that do increase cortisol. Chronic alcoholism actually leads to a state of chronic, elevated cortisol, which isn't good. Also, just for example, fasting, like long fast, does increase. So anorexia, for example, you can have high growth hormone, but then you also then you have low IGF-1, which is the protein from the liver that the growth hormone makes. That's the ultimate thing that does the stuff. So like if we are looking at somebody who, for whatever reason we're evaluating for growth hormone for some reason, it's just good to know that someone with anorexia is going to have high growth hormone, low IGF-1. They might also have high cortisol, even though they're going to be really, really, really thin because they have anorexia and they're not eating. But they have a high stress state too. So those are things where there's a little bit of truth, but then
Yep.
But then, yeah, whether someone is really going to manipulate those hormones in a clinically meaningful way, not really. But again, I always tell people, okay, we're going to try to optimize your base, hormone function, but that just goes with everything. So improved diet, exercise, sleep. Sleep's really the unsung hero. We're always going to do that. And that's not just about hormones per se. That's just because hormones are part of it. Kind of like, you hear about metabolic damage, which is not a real word. It's really metabolic adaptation, because when you diet, when you lose weight, we have hormones that change, that, I tell patients with obesity, they kind of work against us. And that's not metabolic damage. That's just metabolic adaptation. Our thyroid axis kind of calms down a little bit, kind of like what happens when people are really ill. The thyroid axis kind of calms down. So,
okay.
Those are ways that diet, exercise, stress, sleep manipulate our hormones, not in a hugely clinical ways though. And dietitians, exercise physiologists, trainers, they can help everyone improve their health. And with that, you will see at least numbers, maybe associated with a little bit of increased hormone optimization, we'll say, like maybe a guy's testosterone, let's just say, goes from 300 on average to 400. Well, that may be, but then you gotta look at binding proteins and what was free testosterone. And oh, by the way, your levels of testosterone change all the time. They peak in the morning while you're fasting in the morning.
Yeah.
There's all sorts of different things that relate. People go, oh, I got to get my testosterone levels here. Well, no, you don't. We just got to make sure you don't have hypogonadism from a pituitary tumor or some testicular problem. But otherwise, we're always going to try to optimize everyone's diet, exercise, sleep. And with that comes kind of the theoretical hormone optimization, if you will. But as far as really, really manipulating hormones, no. And if you have a pathology, like, if you have a pituitary tumor, testicular failure, or anything else, if you have Hashimoto's, your thyroid doesn't work, you have thyroid surgery for whatever reason, pituitary surgery, no, lifestyle's not going to manipulate your hormones when you actually have a problem.
So again, I asked you a question and it immediately gets into a comparison between acute, pathology and the general population. And so that's good that we're being consistent with what we're sort of uncovering and discovering here. Well, you've answered all my questions very well, and I've enjoyed speaking with you. And I know you're a busy guy, so I don't want to take any more of your time unless you have anything else you want to add, or do you have anything you want to promote at this time?
Oh, no. I mean, people can, follow along on Facebook, Instagram, whatever. Nothing otherwise to promote.
So what do you like to do on social media?
I'm more, I would say, patient-oriented. I try to share studies or anecdotes or even maybe what I'm doing that I think might help my patient population, which is, kind of the average group of people who, might struggle with obesity, diabetes, lipid issues, heart disease risk. And then once in a while, other hormone problems beyond that. But those tend to be more rare. I mean, thyroid problems are pretty common, so I'll share stuff about that once in a while. Not many patients are truly interested in some of the more, the specific endocrine things like Cushing's disease or, acromegaly, which is too much growth hormone, stuff like that. But osteoporosis is another one I like to share stuff on, because things where people can do something about it with diet, exercise, sleep, behavior modification. I like to obviously push as much of that as we can, because, we can work on the other things, but we need everyone to be optimizing those for some of the reasons we talked about. And it is complex. I mean, these guys out here that say they can do all this hormone stuff, you're right. One of the main lessons to really learn, because, we talk about complicated things and stuff is complicated, but we definitely want to optimize diet, exercise, sleep, which is going to optimize the best we can our hormones per se, unless there's a true pathological problem. And then that means you need our assistance. But we're always going to try to optimize diet and exercise and sleep and stress reduction and everything else. So,
absolutely. Yeah, and I appreciate you making that point extremely clear, because we're certainly not trying to, be down on the fitness industry, dietetics, nutrition, because we need all that. I mean, that's what I do.
Yeah, I was going to say, but you're right. The caution is to have a very healthy skepticism of anybody trying to sell you anything related to like hormones. Just because, hey, hormones are sexy. That's why I'm an endocrinologist, right? So I get it, but but be very cautious and don't buy anything from somebody. If there's really a concern, you should see your physician. If you need a referral to an endocrinologist, that's potentially appropriate. But otherwise, just know that you can be healthier with all the lifestyle measures. But if there's a concern, you should get checked out.
Absolutely. Well, that's very well said.
Overcomplicate some matters, but yeah, embrace the complexity. But overall, we ultimately have to act with some simplicity. So.
Yeah, no, I do really embrace the complexity today because it really helped illustrate what I was trying to discuss today. I really appreciate your time. Your time here is going to help a lot of people.
Sounds good. Yeah, and I can give you some references if necessary too.
I'm sure you can. Thanks, Karl.
All right, man.
Have a good day, dude.
You too. Bye.
Bye.